Good afternoon once again. My name is Kimberly Fowler, and I am the Director of Technical Assistance and Research here at the National Council of Urban Indian Health. Thank you for joining us today for this Behavioral Health Community of Learning webinar titled Understanding Trauma excuse me, and the Basics of Creating a Trauma-Informed Agency. The Behavioral Health Community of Learning is specifically geared towards behavioral health staff that are working on the ground in urban Indian communities, as well as open to all those that have an interest. By providing you with relevant information and practical tips, NCUIH aims to support you in being successful in your clinical and outreach activities. Today's Community of Learning will feature a presentation from one of our own staff, Mr. Ryan Young, who will be sharing with us an overview of trauma, its implications in the work we do, and the basics of creating a trauma-informed agency. Mr. Young serves as the Technical Assistance and Research Center Coordinator here at NCUIH. He earned both a Master of Social Work and a Master of Public Administration from Grand Valley State University, and he obtained his undergraduate degree from Marymount Manhattan College, majoring in psychology. Much of Ryan's career has been spent working with minority populations within various initiatives to reduce health disparities and improve health outcomes. Prior to joining NCUIH, Ryan served as a limited licensed social worker at a Michigan community school. He provided all aspects of clinical care to at-promise minority youth and their families, including the Latino and American Indian Alaska Native populations. Finally, he serves as the Secretary of the Board of Directors for a nonprofit that advocates for the intellectually and developmentally disabled. So as I mentioned before, as a reminder, you may post questions at any time in the Q&A pod to be answered following the presentation. So without further ado, now I would like to turn it over to Ryan, today's presenter, in order to present on the basics of creating a trauma-informed agency. Go ahead, Ryan.
Hello, everyone, and thank you for joining me. Today's webinar will cover a lot of material, and it's my intent to provide an overview of trauma, the importance of trauma-informed care, and provide you with a blueprint for the foundational work in creating a trauma-informed agency. And some of the things that we're going to look at, we're going to define trauma. We're going to discuss the types of trauma. We're going to examine the impact of unaddressed trauma. We're going to define trauma-informed care. We'll discuss the importance of being trauma-informed. We're going to provide the basics of a trauma-informed agency, and then provide you with the initial steps in becoming a trauma-informed agency. Learning objectives for today, you'll be able to define trauma and understand the different types of trauma. You can discern unaddressed trauma. You can differentiate between trauma-informed care and a trauma-informed approach, and understand the fundamentals of beginning to develop a trauma-informed agency. So, what is trauma? Trauma is the elephant in the room, yet it's the elephant that is often ignored. And when trauma is ignored or it's not properly addressed, it repeats itself over and over. And something important to consider with trauma is that as we experience it, it does not get processed the way that other experiences are processed. Many unpleasant experiences, such as the breakup of a relationship, are often processed through a series of stages. Early on, the experience is present and alive, and slowly the experience transforms through processing. And then we're processing our loss. We can grieve and mourn that loss, and eventually that unpleasant experience becomes part of our story. And at some point, we're able to talk about it and think about it without experiencing the overpowering emotions that we felt at the time of the event. And so through processing, our experience of the event does change. And then the event becomes a memory. And while it's not necessarily a pleasant memory, it's a memory nevertheless. But when we experience trauma, it's this processing that becomes compromised. The intense feelings don't subside, and the event doesn't become a memory. The experience remains alive, it's active, it's present, it's within us. And so when a person suffers from trauma, it is as if that event just happened yesterday. And that's when we hear terms like flashback and re-experiencing. And when the experience remains alive, active, and real, then it has a big impact on how that individual functions and on the quality of their relationship with others. Trauma hides in plain sight. And so while it's also the elephant in the room that's often overlooked, trauma does hide in plain sight. And so with this picture, see if you can find the hidden tiger. And it's right there in the tiger's stripes. It says the hidden tiger. And that's a lot how trauma is, hiding in plain sight. So let's define trauma. A telltale sign of trauma is that that an experience is traumatic is that it will overwhelm our emotional, mental, and physical well-being. These experiences also overwhelm our ability to cope. These experiences can also include chronic adversity, such as homelessness, racism, so forth. And lastly, according to Judith Herman, this inability to cope is characterized by feelings of helplessness, intense fear, loss of control, and threats of annihilation. It's this threat of annihilation that can also be a perception where a person feels that their life is in danger. They don't necessarily have to be in actual danger. It's just the perception that they are. So what's a traumatic event? Well, to begin, events are neither positive or negative. What's important is our perception of the event. And as stated, traumatization happens when our capacity to respond to a perceived threat is overwhelmed, and that results in the inability to cope. It's important to note that a person's traumatic event may not affect another in the same or similar situation. And trauma also presents in ways that are not always obvious. These things are important to remember as they determine the meaning a person makes of the event. This can be the stories we tell ourselves, even if unconsciously, about the event. It's the meaning-making where lots of people get stuck in trying to process a trauma. People can blame themselves for events. People may tell themselves that if they were stronger, better, or whatever the case, they could just get over it. And sometimes they replay the event, noting that if they had done something differently, they could have changed the outcome. And then sometimes there's self-blame, and that can be as simple as a child thinking they are bad, so a particular event happened. And personally, I've seen a number of times with children that are traumatized by domestic violence, and often the child will blame him or herself, and if they had done something different, or if they were somehow better, then the event wouldn't have happened. But these reactions to trauma, they are normal. It's important to normalize them. Normal responses to abnormal situations. So it's to situations that are anything but normal. Talk about the stress response. So what exactly happens when these normal reactions to abnormal situations arise? Well, we can fight, flight, or freeze. That's your stress response. And it's at this point that a person no longer feels safe. The stress response begins in our brain, and when we perceive a danger, information is sent to the amygdala via the various senses. And this part of the brain plays a part in the processing of emotions and interprets images and sounds. But when we perceive danger, the amygdala sends a distress signal to the hypothalamus. And then after the amygdala sends that distress signal, the hypothalamus activates the sympathetic nervous system by sending signals to the autonomic nerves into the adrenal glands. And then adrenaline is released, and at this point a number of changes happen. Adrenaline circulating throughout the body. The heart beats faster than normal. It's pushing blood to the muscles, the other organs. The pulse rate, blood pressure go up. And the person undergoing these changes also starts to, of course, breathe more rapidly. Then there's extra oxygen to the brain. It increases alertness. Sight, hearing, and other senses become sharper. But these changes happen so fast that we aren't fully aware of them. In fact, the visual center has not even had a chance to fully process what's happening. That's why people are able to jump out of the path of an oncoming car and without even thinking about it. As this initial surge of adrenaline subsides, the hypothalamus activates the second component of the stress response system. The hypothalamus then releases hormones that signal the adrenal glands to release cortisol. At this point, we're all revved up and on high alert, and we're no longer rational. So, but eventually, as the threat subsides, the cortisol levels fall back to normal. And so this stress response is evolutionary, and while these normal responses to abnormal situations, these responses are not necessarily rational, and they can prevent us from processing and learning and being present in the moment. And they also don't allow for emotional regulation. So a big part of addressing trauma is learning how to regulate one's emotions. Here are some physiological reactions to the stress response. Going to have lightheadedness, tight chest, rise in blood pressure, shaking, trembling, increased heart rate, tunnel vision, muscle tension, inability to focus, sweating. I'm going to do a poll now. Should be coming up on your screen in just a moment. Do we have to poll up? Okay, so in your estimate, what % of the population has experienced at least one trauma in their lifetime? Looks like everybody's thinking it's 80%. So let's look at how common trauma is. So 6 out of 10 men have experienced at least one trauma in their lifetime. And 5 out of 10 women have experienced at least one trauma in their lifetime. Now we're going to look at the types of trauma. So there are many different types of traumatic stress, as you guys probably are well aware of. We have early childhood trauma, childhood neglect, physical abuse, assault, sexual abuse, assault, psychological, emotional abuse, accidents, forced displacement, refugee, war zone trauma, disasters, cultural trauma, complex trauma, which is particularly interesting. The trauma is no longer a single event, but rather a sort of bucket of experiences. System-induced trauma, such as systemic racism, community violence, homelessness, medical trauma, traumatic grief, separation, multi-generational or historical trauma. And it's this last one I want to spend a bit of time on, the multi-generational or historical trauma. And it's particularly relevant to Native Americans, yet it's often overlooked by the mainstream healthcare system. So at this slide, we're going to look at some sources of intergenerational historical and cultural trauma for Native Americans. We have ecocide, the destruction of the native food sources, resources. Culturecide, removing somebody from their cultural practice. Forced genocide, legal sanction to murder natives. Removal, forced off land. Assimilation. And this is a tactic for acquiring more land and the eradication of native culture and cohesiveness. And that does include the relocation policies of the 1950s. Separation and forced separations from family and land. And that includes boarding schools, and also removing CPS, Child Protective Services, removing children. And then racism and stereotypes. And with the stereotypes in mind, I would say that it's possible that ethnocentrism also plays a role in perpetuating this intergenerational or historical trauma. So the two concepts of intergenerational historical trauma, they're related, they're similar, they're interrelated. But the main difference is that historical trauma is more macro in nature versus intergenerational trauma, which typically concentrates on the family level. Multiple generations within a family can transfer the impact of trauma over the years. And historic trauma is often related to the status of being part of an oppressed group. And often both of these, intergenerational and historical trauma, they sort of morph into a mix of contemporary complex trauma. So what does this mean for kids in passing trauma on to the generations? Those that come from a background with intergenerational or historical trauma are typically at the highest risk of experiencing trauma, and they often have much more difficulty in working through trauma because they come from a family where there was trauma in the parents or in the grandparents or previous generations prior to the grandparents. And this concept originally became of interest to the academic community when looking at the children of concentration camp survivors. And they presented as if they themselves were in a concentration camp when they, of course, weren't. There's many social determinants in which Native Americans have high rates of disparity, including rates of addiction, suicide, mental illness, sexual violence, and all these things are influenced by historical trauma. And so trauma in the parent is transmitted to the child through the attachment bond. And there's also, from the parent, there's this negative messaging that the world is not a safe place. People can't be trusted. There's always danger around the corner. And kids definitely pick up on this. Some research indicates that the impact of both intergenerational and historical trauma can be passed through the genes. Essentially what happens is the genes that are governing the stress response, they get switched off, and it's allowing for more negative responses to stress and trauma. But within Native communities, the responses to these traumas, you could have survival guilt, depression, psychic numbing, fixation to the trauma, low self-esteem, anger. All of these things, they can often lead to self-destructive behavior, substance abuse, domestic violence. In addition to these cycles of genocide and disenfranchisement, which they were also subjected. And so Natives have also been deterred from addressing grief in a self-determined way by federal prohibitions against their ceremonial practices, the takeover of sacred spaces. And so when we see historical grief become interwoven with historical trauma, and it's important that clinicians be mindful that the pain children experience may be related to the pain that their parents, grandparents, and ancestors experience. And also, reminders of racial discrimination can also exacerbate one's response to trauma. For instance, when Michael Brown was shot in Ferguson, Missouri, his body was left on the street for hours, and that left many feeling outraged at this lack of human dignity, and that was heaped on the already existing systemic race issues in that town. And so clinicians should be very careful of how a client's trauma is characterized and remember to consider the family and the cultural message as well as the individual response. For instance, adaptive behaviors such as a person of color teaching a child of how to calmly respond and behave when faced with being stopped and detained by law enforcement. That sort of thing can be normalized within a given culture, but yet that same normalized behavior can also be experienced as trauma on the individual level. we're going to look at culture and trauma. There are three elements that shape how we respond to trauma and the treatment of trauma. First one we're going to look at is culture. And responses to trauma can be influenced by culture and history, and when working with Native children and families, commissions should investigate the possibility of multi-generational trauma, as we talked about before. But it's also important to look at how the family and community frames the loss. How are they telling their story to each other, to themselves? The next component is your relationships with others. And some things that can impact this element are whether or not a supportive environment exists. And that's probably the most important factor. There are other factors that could come into play. For instance, if a client is codependent, for example, a codependent person typically has poor boundaries and could be more passive in their interactions. And then relationships can be dysfunctional in which unhealthy behaviors can cause chronic difficulties, such as lack of proper self-care. And this last element is understanding and interpreting of events. And these are the stories that we tell ourselves. And again, that's the making meaning of the event itself. Is the event something that happened to me, or does the event define me? Did I do something to deserve it? Is there something I could have done to prevent it? Should I have prevented it, etc.? Now we're going to talk a little bit about unaddressed trauma. So why is unaddressed trauma a problem? Well, it's a problem for a number of different reasons. But this unaddressed trauma and ongoing stress response can result in serious changes to one's emotions, cognitions, memory, and state of arousal. Traumatization is essentially a stress frozen in place. A person can become locked into a pattern of neurological distress that doesn't really go away by returning to a state of equilibrium. And trauma creates imprints in the brain. And when those imprints, these memories, are stimulated by a triggering event or experience, the effect may be disassociation or hypervigilance. And when the stress response becomes the new normal, it's no longer an acute chronic hyperarousal. Or it's no longer acute, but hyperarousal can resolve. And this is the brain is responding to stressors. It's every event is threatening your safety. And this really explains the overreactivity that is often seen in those suffering from unaddressed trauma. This overreactivity can, in fact, a whole host of somebody's areas of life functioning. It can increase the susceptibility to neurological, neurobiological, physiological changes, including the susceptibility to mental health problems, including PTSD, hostility, depression, anxiety, substance use, suicide. And then physical problems can arise as well. The impact of trauma is, of course, it's individual to each person, but here are some of the many problems that can arise from untreated problems. Relationship problems, alienation, low self-esteem, difficulty in cognition, emotional difficulty, anxiety, that's a big one, eating disturbances, sleep disturbances, chronic pain, depression, there's another big one, memory disturbance, panic attacks, impulsive behavior, emotional numbing, and of course, angry outbursts. So here we have a picture of a poker player in a poker tournament. We've all heard of a poker tell, and in this picture, it looks as if the guy his lips are pursed. These pursed lips, they can indicate a number of different things, but in this case, I think the poker player is tense or frustrated. Pursed lips can also indicate evaluation. Maybe he's deciding between two possible options. And so like poker tells, a person with trauma also has tells. These are the nonverbal cues, and they're significant in conveying information. They're subtle, and they can be picked up from a client's body language, tone of voice, etc. And it's noticing these patterns and changes in body language that it could give us a greater insight into what patients may be experiencing. Sometimes the effect of trauma become ingrained in the patient's body language, almost if it's muscle memory. And sometimes when the hyperarousal state kicks in, the client may try to subconsciously try to calm themselves without even realizing it. And maybe they're clasping their hands, they're stroking their hair, something like that. The bottom line is never underestimate the importance of body language, and remember to pay attention to the person's nonverbal behavior. So what is trauma-informed care? Trauma-informed care, it moves us from a place of what's wrong with you to a place of what happened to you. So why be trauma-informed? Well, there's a number of reasons as to why primary care providers should incorporate trauma-informed care into their practice. And here are 6 reasons. First off, trauma is not always easily recognized by the healthcare provider and the client, him or herself. It can halt the parental transmission of trauma. It can reduce re-traumatization. That's very important in primary care. Another big advantage is it can help stop the cycle of the adversarial client relationships based on stress. It also can help prevent clients from falling through the cracks. And another important one is it can help the staff cope with vicarious trauma, compassion fatigue. Now we're going to look at the trauma-informed approach. So, according to SAMHISA, SAMHISA believes that the trauma-informed approach consists of 4 R's. The first one realizes the impact of trauma. It realizes the widespread impact of trauma and understands the potential for paths to recovery. The second R recognizes the signs and symptoms of trauma in clients, families, staff, and anybody involved within the system. The third R responds by fully integrating knowledge about trauma into policies, procedures, and practices. And the fourth R, SAMHISA says re-traumatization, but I'm going to say resist, but it resists re-traumatization, which is very important. So there's not a set of procedures or practices that result in a trauma-informed approach. Rather, a trauma-informed approach, it follows SAMHISA's 6 key principles. These principles are generalizable across settings, but actual implementation may vary. But a trauma-informed approach promotes the following: safety, trustworthiness, and transparency, peer support, collaboration, empowerment, giving the client voice and choice, and it promotes cultural, historical, and gender issues. And it's important to note that a trauma-informed approach can be implemented in any type of service setting, and of course including primary care. Yet, excuse me, it's not the same thing as a trauma-specific intervention or treatment. And that would address the impacts and symptoms of trauma to promote healing. And there are a number of different modalities and interventions that are trauma-specific. Seeking safety is a well-known one, but discussing these specific interventions really goes beyond the scope of the webinar. But there's a number of them out there. Essence of being real, risking connection, sanctuary, I said seeking safety, There's just a bunch of them. Now we're going to transition into talking about the trauma-informed agency. So the basics of a trauma-informed agency. A trauma-informed agency is one where the staff recognize the impact of trauma on one's mental and physical health, and they respond accordingly. And so it's this culture of the trauma-informed agency. It's anchored by those 6 SAMHISA principles that we mentioned before: safety, trustworthiness, peer support, collaboration, empowerment, and the cultural, historical, and gendered issues. Big question is, when is an agency trauma-informed? When an organization can truly say that its culture embraces and reflects those 6 SAMHISA principles that we talked about in each and every contact with a patient or client, in every setting in the organization, in all the activities, and in all the client and staff experiences, then the organization is trauma-informed. And so the organization can build on those SAMHISA principles so that service providers are doing a number of different things. They're going to have regular screens for trauma and its symptoms, and that's for new and existing clients. There's going to be culturally competent and appropriate assessments and treatments for trauma. You're going to view the patient holistically, but always look at things through that lens of potential trauma. You're going to reinforce the patient and staff feelings of a self-welcoming and protective environment, and offering unconditional positive regard for all people that walk in the door. You're going to consider the impact of trauma experienced by parents, caregivers, and the family system. You're going to devote time and resources to the importance of staff practicing good self-care to mitigate compassion fatigue. Let's do another poll.
Do you see it? Yeah.
Has your agency taken any steps to becoming trauma-informed? Like most of you have. Now we're going to look at agency development. Let's look at trauma in the primary care setting. So according to person-environment systems theory, we need to consider the life situations that could be contributing to a person's current and physical mental functioning. Many of our clients or patients present with issues that could be related to traumatic life experiences. And most importantly, we have to remember triggers. And people who have been traumatized are often sensitive to the cues that remind them of the people, places, things, feelings, smells that were involved in their traumatic experience. These are triggers. And they can effectively cause someone to relive a trauma in their mind. Sometimes triggers are not readily known to a person. Consequently, the UHIP can be viewed as a place of stress and unease as opposed to a place of wellness. look at some of these triggers in primary care. First off, we have sites. There's lab coats, there's medical equipment, could be restraints, an x-ray bib, needles. We have sounds, dental drill, there could be ambulance sirens. That might be something more associated with the hospital, but it could be chaos in the environment, crying kids, sound of the door buzzer, the sound of the phone ringing, phone system. Smells, cleaning agents, rubbing alcohol, the smell of latex gloves, just about anything you could imagine could be a potential trigger in the primary care setting. And so things that contribute to the client distress, definitely we have invasive procedures. The removal of clothing, that's a big one, particularly if someone had been sexually assaulted. Physical touch, it's how the client might be touched. With this in mind, a number of children that I've worked with that have experienced trauma, this physical touch comes into play in the classroom. And there's this education component, working with the teacher of how to approach the child, not from the back, touching them from behind, but approaching from the front, looking in the eyes, etc. We have personal questions that may be embarrassing or distressing. Power dynamics of the relationship. Gender of the healthcare provider. Here's another big one, a vulnerable physical position. And of course, the loss or lack of privacy. And so some signs that a person may be distressed, I mean, you're going to have emotional reactions, anxiety, fear, powerlessness, helplessness, worry, anger. Sometimes there's physical reactions. They might be nauseous, lightheaded. There's an increase in blood pressure, headaches, stomach aches, etc. Maybe even holding breath. Behavioral reactions, that's a common one. Uncooperative, argumentative, unresponsive, restless, maybe even crying. And then there can be cognitive reactions. Maybe their memory is impaired, they're forgetful. There's an inability to provide an adequate history, adequate medical history. With all of these reactions, we could have avoidance of medical and dental services. We could have a non-adherence to treatment. Someone might postpone mental or dental services until things get really bad. There might be misuse of medical treatment services. For example, someone might overuse ER services. The ER becomes the place of primary care. Someone might misuse their pain medication. So trauma-informed screenings and assessments. And a trauma-informed screening refers to a brief focus inquiry to determine whether an individual has experienced specific traumatic events. This is often done in an intake. It might be a questionnaire with the other forms that a new patient might fill out. As compared to the trauma assessment, and the trauma assessment is a more in-depth exploration of the nature and severity of the traumatic events, and the consequences of those events, and the current trauma-related symptoms. That's something that's going to be administered often by a social worker, but a trained professional. So why do trauma screenings? Well, obviously we want to address the impact of trauma, and trauma-related symptoms are often not evaluated, and therefore they go unrecognized and untreated. And for example, a child diagnosed with ADHD is more likely to have experienced family stress and trauma early on in life, and that can exacerbate the ADHD symptoms, and that poses diagnostic challenges with respect to teasing out whether the symptoms directly result from the trauma they experience or not. And so the commitment to trauma-informed care and the effective delivery of culturally competent trauma-informed care can only be as effective as that organization's commitment. And this commitment must extend from the top down and includes all employees, administrative practices, policies, procedures, program design, staffing patterns, supervision, your organizational evaluation, assessment, and your consumer feedback. The organizational self-assessment it's going to be the first important step towards moving to becoming a trauma-informed agency. And we're going to revisit those 6 key principles, SAMHISA 6 principles: collaboration, empowerment, safety, trustworthiness, culture and gender, and choice. And so with collaboration, is your agency maximizing its potential collaboration and sharing power to add public value? Do consumers have a significant role in planning and evaluating the agency services? That's very important. So how is this collaboration built into your agency activities? An important question to ask is, do you have a consumer advisory board? Let's move on to empowerment. And do trauma survivor patient advocates have a significant voice in the planning and evaluation of your services? Does your staff practice a strength-based approach in their routine interactions with patients, particularly in medical advice, in which the patient's strengths and skills are recognized, as opposed to going from a deficit-based perspective, you should, you shouldn't, that kind of language. And do you offer a message of hope is really what's important. And of course, Western medicine can tend to be deficit-based. And does your program communicate a sense of realistic optimism about the capacity of consumers to reach their goals? Safety, we want to ensure the patient's physical and emotional safety. Sometimes this is overlooked. And so you want to look at how safe is the area around your clinic? Are your sidewalks and parking areas well lit? Do patients need to walk far to get from the building to the program entrance? And is that walk safe? Are the directions to your clinic location readily available? And are those directions simple and clear? So what makes sense to you may be confusing to others. And once the patient arrives, our directions to the reception area or other areas they need to go, are those directions clear? Trustworthiness. Trustworthiness is maximized via task clarity, consistency, and good interpersonal boundaries. Some questions you might consider for this key principle: does your clinic and staff provide clear information about what will be done, by whom, when, why, under what circumstances, and at what cost if that's an issue, and what's the goal of what it is that you're going to do? Is your staff moving towards a more friendly, potentially less professional boundaries with each other and their clients? This can involve such things as personal information sharing, touching, exchanging of home phone numbers, contacts outside professional appointments, loaning money, etc. Of course, those things don't necessarily mean that it's moving towards less professional boundaries, but those are some things to keep in mind. Culture and gender. Do men and women have different access to or the control over the resources in the agency? If so, to what extent? Is there gender awareness on forms and brochures, publications, etc.? You have to look at to what extent do you reach out to culturally diverse groups in the community, and are they involved in the organization and its policies and procedures? This inclusion definitely should represent populations like the physically disabled, the intellectually disabled, the LGBTQ, etc. So don't just limit it to race and ethnicity. And does the cultural composition of your board reflect the population that you serve? And you want to identify any barriers that limit participation of culturally diverse groups. Lastly, let's go on to choice. And with choice, we want to maximize patient control and choice. How much choice does the patient have over the services received? How much choice does a patient have over when, where, and by whom the service is provided? That could be maybe the day or the time of week, the office versus a home visit, other location, maybe the choice in the gender of the healthcare provider. And does the patient choose how contact is made? By phone, mail, home, other address? Moving on with the self-assessment. So the implementation of trauma interventions and treatments without first assessing your culture, that can neutralize any potential positive gains that any interventions could bring about. The assessment should highlight areas for improving both your trauma-informed culture of the organization as well as the interventions themselves. And lastly, the assessment is a tool that can be used through all stages of program development, including implementation, monitoring, and evaluation. So after your organizational assessment, so once it's completed, you'll be better able to gauge and tailor the next steps to becoming more trauma-informed. You'll be able to assess what's your capacity, and that might guide the actions to take. So translating the guiding principles of trauma-informed care into practice, it definitely takes time and commitment, and some actions that should definitely be included is staff training and education. Staff should begin to understand the impacts of trauma. They should receive trainings to interact with patients with empathy, sensitivity, and respect. The agency should provide trainings on secondary vicarious trauma and certainly develop ways to support the staff in that area to ensure that the staff is practicing proper self-care. You're going to want to create a safe environment, a safe place. Creating an environment of staff support that's supportive, welcoming, respectful. In general, that's also crucial to providing quality care to trauma survivors. And lastly, a big one is consumer voice. A trauma-informed primary care agency should offer a collaborative, supportive environment. And the healing of trauma survivors is often tied to their ability to regain control of their lives. And organizations should facilitate empowerment by giving consumers a voice in what happens on a daily basis. And remember that you and your staff are ambassadors for your brand. Patients need to feel welcomed, valued, understood, and safe. And lastly, the outcomes of becoming a trauma-informed care agency. There's more patient buy-in for care recommendation. It's very important. It's more cost-effective and better in producing positive health outcomes than, of course, just merely treating the symptoms. And trauma-informed care for children definitely leads to better outcomes, better self-esteem, improved relationships, and increased safety. Now, here are some resources for your self-assessment. These are all good ones that can help you with those initial stages. I have some on the next slide here. I want to thank everyone for attending today's webinar. Can address any questions that you might have at this time. There's also, we'll be sending out a short evaluation of today's webinar. We'd certainly appreciate it if you would take the time to complete that.